Hey, welcome everybody to our meeting Monday morning for our central nervous system. We're going to try to burn through a lot of stuff today, but I wanted to show you some more about where your nervous system develops from, and then I want to show you one of the most common congenital defects that happen in embryos. So one of the most common embryonic disorders that we have called spina bifida. So we're going to go ahead and look at my PowerPoint. Maybe. There we go. And let's get that going. Okay, so we're checking out embryonic development again. I have a little short video to show you, the one that I wanted to show you on Friday, but I didn't find it yet. But I have it now. All right, so we're gonna watch this and I'm gonna talk over it. So I'm gonna turn down my speaker a little bit. Hopefully it won't be too loud. It just is music, it's not words. I don't remember which way is off. Oh, well, there's no sound anyway. Okay, that's good. All right, so here is you. You were just this section right here. The rest was the egg sac, yolk sac, and then the amniotic cavity above that. So we're looking down on top of you from the back. So this is the back of your body. And you had a tissue back there called ectoderm that covers the surface of your body. And then we had this little primitive streak that orients you from head end to tail end. So your body's going to lengthen. We're going to be about day 14 in here. And so we're going to get, or day 20 actually, a week later. So we're going to get the folding, remember? We're going to get that groove that's going to develop down the back of you. We're going to look at you on cross section. All right, so here is your back. This would be your abdominal cavity down here. Eventually your abdominal cavity, it's not there yet. Here is the dip. And so what we're gonna do is take these two edges and we're gonna bring them together. And so this is what's happening along your back. And fold them and fuse them together. And then we're gonna get these neural crest cells. Then here is your spinal cord. Okay, and so this is your tube, which your brain is going to come from. If it comes out of the picture, would be where your head end is. So here is your head end, here is your tail end, and here is that tube. So we're folding in to eventually get that tube forming, and we'll watch that. So we're going to seal up in the middle first. And then we're going to see, there we go. So now we're going to seal towards the head end and we're going to seal towards the tail end. And one of the things I want you to notice, so here we are 3 weeks after conception. So now your mom would have been 1 week late after her period at this point. We're going to seal up the head end, and then the tail end doesn't quite seal up all the way sometimes. And we're going to look at a defect that happens when this dorsal end of this neural tube right there where it was dark blue doesn't form properly. So now you have the tube running entirely down your back. And now we're just going to watch that happen all together. Okay, so we're still watching all of that fuse together. And then keep in mind this dark blue area down here at the bottom we're going to look at. Now you're going to start sprouting arms. And we'll just finish watching. So now what we want to do is make some other nervous tissue out in the rest of your body. So we're going to get these cells, and there are a lot of different things that come from neural crest cells, which you'll learn about next semester when we do embryology.
Is this a cross section?
Yeah, this is a cross section. Yeah. So your head would be coming out of the screen and your tail would be going into the screen. All right, and so now these cells are going to migrate to different places in your body. One of the places that they happen, and here you get your adrenal gland. Oh, so down here at the bottom. So we want to look at this neural tube down here at the bottom. So keep in mind, this is the one that can be affected by this disorder that we're going to look at in just a minute. Yeah, we're almost done. Okay, so that's good enough for looking at that. I like that all put together there. So, oh, stop playing. All right, so now we're going to go ahead and look at that problem that happens with the caudal end or the tail end of your spinal cord, and it's called spina bifida.
Spina bifida, or its most severe form, myelomeningocele, is the most common central nervous system or neurologic birth defect in the world.
Myelomeningocele is a defect in the spine. It's failure of the spinal cord to close.
The spinal cord, or the neural tube, as the embryologists say, forms very early in gestation, certainly before 8 weeks gestation. And spina bifida is thought to be a failure of the formation and closure of that neural tube, so that the spinal cord elements are exposed to the intrauterine environment.
It's a progressive process. It's a progressive injury, so that by the end of pregnancy, there's been direct traumatic injury to the spinal cord, and there's been injury from the amniotic fluid itself.
Because of changes in pressure and fluid flow, babies are also at risk for developing hydrocephalus,
which is a fluid buildup on the brain and which damages the developing brain.
Virtually every child with myelomeningocele or spina bifida has an Arnold-Chiari malformation on X-ray. And what it is that the back part of the brain, called the cerebellum, that has a lot to do with control of motor movements, is wedged down into your neck.
The cerebral spinal fluid that cushions the brain and cushions the spinal cord leaks out through the back through the open spina bifida defect. That leads to the back part of the brain.
Okay, I'm going to pause this right here. All right, so I want you to see this yellow that's passing. This is the vertebral column. This yellow is the spinal cord material, and then here are the nerves. Now, because this didn't fuse, they didn't come together all the way, this is the spinal cord extending out of the skin. So here's the skin on the top. Here are nerves that are trying to go through into the organs, the legs and the muscles down at the bottom, lower half of your body. And then as the baby, its back hits up against the mother's womb, okay, so the inside of the uterus, then the cerebrospinal fluid can leak out, and then it showed you in the view before that there was some necrosis, some damage, real serious physical damage that's happening to the spinal cord at that level. And now we'll look at, well, if the cerebrospinal fluid is leaking out, what's going to happen up here on the brain end?
That leads to the back part of the brain getting sucked down into the upper part of your spinal cord. That in turn can block the circulation of cerebral spinal fluid in the brain, because the fluid is produced in the brain and there's no way for it to circulate beyond that blockage point.
So if there's a blockage in the...
Okay, so I'm going to stop that right there. So because of that change in pressure, because there was less stuff down here, less cerebrospinal fluid down at the bottom, now I had more pressure up here that's pushing the cerebellum and the brainstem down into filling up this gap right here where the cerebrospinal fluid should be flowing. So now it can't flow, and now it's going to build up in the lateral ventricle and the third ventricle, and we're going to get a disease called hydrocephalus, or a disorder called hydrocephalus. And we'll be looking more at that at the end of this chapter.
Flow of that fluid, then the water builds up inside the ventricle. So you've probably heard the term water on the brain. The water isn't on the brain, it's inside the brain. If you don't treat that, then you end up with a massively enlarged head, you die, or you end up with severe mental retardation.
So in order to minimize that ongoing damage of pressure from the fluid, the pediatric neurosurgeon places a shunt tube.
It's a simple device. This is a shunt. It's made out of silicone. This end goes through a hole in the back of the head into that water cavity and tunnels down into the skin and goes into the abdomen, which is able to absorb the fluid. It's not a cure. It treats the symptom. It doesn't treat the disease.
Once you have a shunt, there are multiple complications that can arise from it.
The shunt can become infected, which is a serious complication because then the brain and the layers of the brain can become infected with meningitis and encephalitis. And with each bout of infection, that can affect the brain function.
And then, of course, there are mechanical problems. They clog, they break, they get to be too short, they migrate.
So it's not unusual for a child with spina bifida who has a shunt to require that shunt, and not only for life, but to have that shunt changed at least 5 or 6 times during the course of their life.
It's important for parents to understand the potential complications or ramifications of spina bifida after the diagnosis is made.
A child may experience difficulty with apnea, forgetting to breathe. They may also have breathing problems, choking, blue spells.
In the worst case, you end up with a child that's on a ventilator with a tracheostomy and a tube in the stomach to eat. And that is a huge impact on your quality of life.
Spina bifida can cause paralysis in the lower extremities that can interfere with the baby's ability to walk, or they may even be wheelchair dependent.
They also have difficulty with their bowel and bladder function.
Most of these kids, when they become older, have to catheterize, or else they have to wear diapers.
They can develop significant curvatures of the spine because of instability, bony instabilities of the spine if they have a high lesion.
Because of the lack of innervation to the feet and the ankles, there can be the formation of club feet, or the medical term is talipes, as a consequence. So that requires orthopedic intervention after birth.
And then there are problems that can come on later on in life. It's not even necessarily done when you're a baby. You can get tethered cord, which means that the nerve tissue gets caught up in scar tissue and you can lose function. So it's a lifelong issue of disability.
Okay, so yeah, spina bifida can be a problem. And I used to work at a handicap camp back when I was your age, between my freshman and sophomore years of college. And I had some campers. It was out in the woods, and so the kids would come, and we had dormitories, and they would stay for a week at a time. And so we had 1 week was juvenile physically disabled, and so I had some kids that had spina bifida, and they were in wheelchairs, and they did have a variety of symptoms. Not everybody had the same degree, I guess, not variety, but they didn't have the same degree of symptoms. So I had some that were more highly functioning than others, needed more care, some needed less care. And then I had a student just about 2 years ago now, maybe a little bit more, and she had posted on Facebook. She had just had her ultrasound of her most recent baby, and said that my baby has spina bifida. And so I hurried up and I texted her and I said, you know, have you checked out what your options are at this point? And so I had told her some things that I'm going to tell you here in just a minute. And she said, yeah, we've already been contacted about this treatment. And so they were preparing to see if they were going to be evaluated for that treatment. So I'm going to show you what the treatment is, and I'll talk to you more about this student and her baby. All right, so one of the things that we can do now is repair spina bifida in utero. So this was the very first in utero, so that means the baby has not been born yet. The mother is still pregnant with this child, and they do the surgery while the baby is still in the womb. And it's amazing. And the earlier that you can treat spina bifida, we're finding the less severe the results tend to be upon birth, and then of course later on in your life. And so we're going to watch this spina bifida repair, and then we'll tell you about my student.
In this fetus with spina bifida, you can see an opening in the back with an exposed spinal cord. Prenatal repair is usually done between 20 and 26 weeks gestation. Once the mother is under anesthesia, we make an incision in the abdomen to expose the womb. The womb is then opened to expose the back of the fetus using a specially designed staple to control bleeding. The tissue over the defect is then opened and removed.
So that's all the damaged
Next,
tissue.
the spinal cord is free from surrounding tissue before it is protected using the dura.
So that's the connective tissue that surrounds the spinal cord. So they
Then
suture that
close the
up,
muscle layers over the defect to further protect the spinal cord.
close up your back
The skin of
muscles,
the fetus is then
close
over
up the
defect.
skin,
If a fetus does not have enough tissue on its back for
close up
primary
the mom.
closure, we will repair the spinal defect using patches as shown here. First, we protect the spinal cord by suturing a patch over it before we lay down a second patch to reinforce the repair. We then close the large skin defect using a piece of skin substitute to complete the repair. We then close the womb and conclude the surgery by closing the mother's incision. Ideally, the pregnancy is continued until 37 weeks gestation before the baby is delivered by C-section.
Okay. So it's so amazing that we can do surgery on a baby while they're still in the womb. So I told my student, I said, you may be a candidate for in utero surgery. And so that's when she said, yeah, we've already been contacted. There was a hospital in Colorado that specializes in this. And so she flew to Colorado and they evaluated her and her baby and said, well, by what we see, your baby's not really a candidate for this particular surgery, which in this case was really good thing because it meant that his spina bifida was not as bad as they had originally thought, and that it wouldn't probably have done much if they had done the surgery, and there might have been more risks than there would have been benefits. And so she just posted a video just the other day of her little boy, so he's not quite 2, and he's just running around and everything, and just it's amazing to see that once he was born that he has a shunt, and so he'll have a shunt for the rest of his life. But he didn't need surgery, and he learned how to sit up and roll over and sit up and walk, and he was of course delayed. He didn't do it at the same ages that most children do, but it was just a great story to realize, you know, he wasn't going to be as bad as they had originally thought. So just really, really happy that that was the outcome of that child's spina bifida. Oh, and then I was going to tell you, because I'll just go back to spina bifida. So the March of Dimes is a fundraising organization that then gives money for research, and originally, because they do it for spinal cord neural tube defects is what they're called. And so the March of Dimes was first founded back in the 60s to help fund research for spina bifida. And so so that's been a very good organization over the past 50 years to really help our knowledge and ability to treat spina bifida. Okay, so we've been through all the ventricles. We're just going to move on, and this is where we ended. Oh, we didn't talk about the fissures. Okay, so the fissure is a deep groove or super deep sulcus, and in this case is going to separate the lobes of the brain between the two cerebral hemispheres. So we go back to this picture, and we look at it from the top, a superior view, we can see, oh, okay, here is the longitudinal fissure. So tomorrow in lab, we'll be naming all of these parts. Okay, so these parts will become very familiar to you after tomorrow in lab. All right, so here's just a lateral view of the cerebrum, is this whole big area, and then the cerebellum down here, and then here is the brain stem. So this would be spinal cord after, if the picture continued on. I'm not going to worry about, well, yeah, we will. Okay, so I want you to see the organization of the the organization of gray matter and white matter. Okay, so let's review what gray matter is and white matter is. So gray matter is everything that's unmyelinated. So interneurons, cell bodies, dendrites, any unmyelinated axons. Okay, so gray matter is everything that's unmyelinated, particularly interneurons. So we want to remember that interneurons are never myelinated. All right, so this is our original plan. So we had the central canal was the opening inside the neural tube, and then there was gray matter around it, and then white matter, which is going to be everything myelinated around that. So if we take a look, if we recall what's going to be here, so I'm going to have a sensory neuron out here, and then it's going to come in here, and then we're going to have an interneuron right here. It goes like that. And then we're going to have our motor neuron that's going to start in this gray matter here and then go out like that, out to your muscles. Muscle out here. All right, so this is how the spinal cord is organized. This is the most primitive of how a nervous system works. Okay, sensory input, integration, motor output. Then as we move up into the brainstem, we have our gray matter around this opening, this central cavity. Okay, so this is all gray matter. Then we have some cells that also migrated out here that we'll probably learn about on Wednesday. Maybe we'll get to it today. But then we had some of this gray matter that's right here actually migrate out into here. So besides having this reflex kind of activity going on, we get this. So we're going to get sensory input coming up here, up through this white matter. And then it's going to synapse with, that'll work. It's going to synapse with an interneuron. So I'm going to have interneurons all up in here until we take it to, a motor neuron that will send the information back out. Whee. Okay, out that way. So all through this white matter here will be the myelinated axons of my sensory neurons coming into my cerebrum. This is where I'm going to think from. So this cortex of gray matter here is where I think. So this is my integration. This is where all of my voluntary motor output's going to come from. And then the axons are going to run through the white matter that's here. Okay, so this is the original floor plan, but then as we developed a brain, then we have neurons here, interneurons here on the outside of the brain as well to increase the surface area for thinking and processing and understanding and planning and all of that kind of stuff that we're going to talk about now. All right, so what is our brain? What does our brain do? So the first part that our brain does, our cerebral cortex, this is where all our consciousness comes from. So this is where all of our perception of our surroundings, seeing, smelling, hearing, tasting, thinking, planning, being, doing, loving, hating, all of that kind of stuff is going to come from, and all of our voluntary motor output. So hugging and caressing and punching and kicking and anything that we do, walking and jumping and absolutely everything that we do is going to come from our cerebral cortex. So what is our cerebral cortex? Well, if we look at this picture back here, this gray matter right here is the cerebral cortex, cortex of gray matter. So this is all of our interneurons. So sensory input will come into it, the motor output will leave from it. So our conscious mind, all of our awareness, communication, remembering, understanding, voluntary movements originate from gray matter, interneuron cell bodies, dendrites, unmyelinated axons, neuroglia, blood vessels. Now it has three kinds of areas, functional areas. So obviously we're going to have sensory areas, so where the information is going to come in. Then we have association areas where we understand, and then we have our motor output. So sensory input, integration, motor output. And I'm sure you've already heard this, a dozen times at least in your life, but what The left hemisphere is going to be concerned with the sensory and motor functions of the right hemisphere. I mean, of the right side of the body, and the right hemisphere is going to handle all of the sensory input and integration and motor output of the left side of the body. Okay, so each hemisphere is concerned with sensory and motor functions of the opposite side of the body. All right, and here is just a picture of what your brain looks like. This is actually a PET scan. A PET scan shows the activity of the muscle, or of the brain, sorry. So we can see this person is probably hearing and speaking at the same time, because this is that Broca's area that Hank talked about in the video on Friday. And so this is Broca's area. This is the speech area. This is the your temporal lobe hearing portion of your brain. And so we know that the person was hearing and speaking while we were taking a picture of their brain, because it's all lit up. It means there's a lot of cortex activity going on. The closer you get to red, the more activity. So over here, not so much activity going on. That's because we don't use those portions of our brain for hearing and speaking. All right, so our motor areas, I'm going to show you the picture and I'll come back to the notes. Okay, so remember, motor is red. So this whole area right here, this whole frontal lobe is all responsible for motor function. Now there's a specific area. Let's see, let's do it in green again. Okay, so this area right here says the primary motor area. So this is where all of our voluntary action stuff comes from. And this is called, put it in red, the precentral gyrus. Okay, so all of our motor output is going to come from that gyrus, that right there. So all of the motor units, if you want to think of it this way, all of the motor units in our skeletal muscle all originate right in here. So all of the signals to go to all of our motor units in our body, in our skeletal muscle, originate from that gyrus right there. Okay, the premotor cortex is this area right here. So this is, if you, for lack of a better way, this is where our muscle memory comes from. Now, you have to think, well, I thought muscle memory was, oops, not muscle motor. I thought muscle memory was in my muscle. No. Remember, your muscles are voluntary. They can't do their own thing. So I don't care how hard you try to learn how to do something and how perfect you get at it, and then you don't do it for a while and you're like, oh yeah, muscle memory, it already knows how to do that. No, that's not right. And I had to tell my son and my husband the other night, I'm like, duh. And then they're like, and then my son was like, oh yeah. My husband still doubted. I'm like, what? But anyway, yeah, so the premotor cortex is where we learn how to do everything. And so we've already planned on how to do everything. You know, if you can hit a baseball really well, or a golf ball, or you know how to do a back handspring, or I don't know, whatever skill, walking, riding a bike, chewing gum and walking, whatever that is, all of that's going to come from that premotor cortex. You learn a piece on the piano, to, you know, a really hard piece, and you memorize it, that's going to come from that area too. Frontal eye field, then this is where your eyeballs move around. Okay, so this is our area that moves our eyeballs. Broca's area. Okay, so this is speech production. So what I'm doing right now, being able to speak, can't speak and write at the same time. Okay, so all of that is the muscles that go to my pharynx so that I can speak, and then the rest of it we'll get to in just a minute. Okay, so those are let's see, let's go back. Okay, so where are the motor areas? Posterior part of the frontal lobe's got that. Primary motor cortex, precentral gyrus, we're going to see the picture in just a minute, allows us to consciously control precise or skilled voluntary movements. Premotor cortex, just anterior to the precentral gyrus, controls learned motor skills or repetitious or pattern behavior, playing the piano, typing, whatever. Used in planning movements, Broca's area, temporal, just near the temporal lobe, for planning production of speech, excuse me, and then frontal eye field, voluntary movement of the eyes. Okay, we're gonna go to this homunculus thing. All right, so this is a homunculus. I know this is a weird looking picture, but once you understand what's going on there, you'll be like, oh my goodness, that is totally cool. So what we've done, we've taken this pre-central gyrus right here, and we've just, this is it. We cut this slice out, so this chunk right here is this piece. We've just pulled it out so that we can look at it. So here is that gyrus right there. And this is where all of our motor units are going to come from. And that's sulcus. So this pre-central gyrus worth of motor cortex, cerebral cortex, I mean. All right, so now what is this weird picture here for? Okay, this indicates the relative amount of motor units that are coming from that part of the body, and where in your body or where in your brain are the neurons that govern that part of your body, where are they found? So if we were to go to right here, so let's say we're right there, that's this part of the cerebral cortex, of the precentral gyrus. So what does that mean? Well, if I were to poke you right there, that would control the muscles that would go to this part of your leg. Okay, so that would make your, well, it would actually go to your quads so that you could extend your leg, so that your leg would swing out like that. Okay, and then if I went here, then it would affect the muscles on your hip. And if I stabbed you right here, it would affect your trunk and your arm, muscles going to your arm, and so on. And then, so if we take a look, let's do hand first, and then we'll do toes, and then we'll do face. All right, so if we take a look at hand, look at how many motor neurons. This whole section of your premotor cortex is dedicated just to moving your hand and fingers. Now, why? Well, because we know that we have small motor units in our hand and our fingers because we need that delicate movement, but we need lots of small motor units. Okay, so that's what's in this whole area right here. Lots of small motor units that are going to our hand. Okay, then we see something similar to that going to our toes, but do we have as much control over our toes as we have over our hands and fingers? No, because we don't use our feet like that. Maybe with a chimpanzee or a gorilla, their cortex might be more like this one, with more motor units going to their hands and, I mean, their feet, because they do use them more like hands. Okay, so just how big the picture is depends on, or describes how many motor units are going to that. Now let's look at your face. Holy crap. Look at your face. This whole section right here is just for your face. But what do we know? How delicate are the movements that occur in our face? Oh, we have so many different facial expressions just with, you know, just a tiny little change in our skeletal muscle under our skin can give us a whole range of nonverbal communication. Okay, so that's why this is so big. And then look at this. Look at how big our lips are. Okay, why are our lips so big? Because we speak. And look at what's over here, Broca's area. Oh, isn't that cool, right? Because now we're right here. So there's where Broca's area is, to help govern how well we speak. And so because we have so many motor units that are going to our mouth and our lips so that we can speak, then that's why they drew them big on the picture. Okay, then we can stick out our tongue. So the motor units for sticking out of our tongue would originate right here, and swallowing. Okay, all right, but then that's all, okay, because we don't have any more skeletal muscle that we innervate. All right, and then we're gonna come over, well, let's just do this while we're here. Okay, so what is blue again? Blue is sensory. So I'm gonna go and pick another color. We'll go ahead and do the pink. All right, so now if we look at right here, that's right here. Oh, that's so funny that that's right there. Okay, there's your butt. So let me tell you about that. When I used to figure skate when I was growing up, oh my gosh, I can't tell you the worst pain, even worse than like falling on your knee or something. I never fell on my head, but worse than falling on your knees or something was when you got a skate blade in your butt, when you fell backwards onto your skate blade. Oh, that was painful. And so where did that input go in my brain? Oh, right there. Okay, so I felt that right there. And what side am I on? On my right side. Okay, because this is the left side of your brain. So this would be, and that should be the right side. This is funky that they drew the wrong side of the face, but whatever. Okay. So yeah, so I would have felt it right there. So same thing, you step on something sharp, that's where it's going to go. Okay. And then again, because we have so much sensory input, our for touch. Okay, so all of that area is dedicated to touch. Our face is very, very sensitive to touch, especially our lip region. Now, here's the cool thing. Okay, remember that babies love to put things in their mouths. Okay, why do babies put things in their mouths? Because guess what? This is the area that is developed first in a baby is sensory input and motor function on your mouth. But we're talking about the sensory input so that they can feel where they're nursing, so they can get the nipple in their mouth. So, and then be able to form their lips around it so that they can nurse. So that's why babies put things in their mouth, is because their brain is already attuned to figuring things out with that part of their mouth, or with that part of their brain, is those neurons right there. Those are the ones that are first turned on. Okay, so so that's why the picture's so big. But if you got poked in the eye, boom, it would go to that part of your brain right there. You break your nose, goes right there. You feel it right there. You go to the dentist, boom, feel it right there when they're trying to give you a shot. You bite your tongue, you get a sore throat. Okay, now there's two things in this picture here on this right side that were not over here on the left. The genital region and the intra-abdominal. Now, the genital region, why is it not over here? Is because the genitals are not skeletal muscle. There's no skeletal muscle in there. So there are no motor neurons, skeletal muscle motor neurons from this region, or I guess they'd be from this region, going to the genitals. Okay, and intra-abdominal, because that's all smooth muscle in your stomach, there's nothing over here to get your abdominal, your what are those called? Digestive tract organs to do things. But you sure as heck feel it. You know, when you have a stomach ache, or maybe you're lactose intolerant and you can feel that bloating and everything like that. Okay, so that's where that's going to be. So this is where you don't feel good with your stomach. Anything like you're nauseous or whatever, that's all going to go right there for you to know that feeling. Okay. All right. So that's the motor areas. Now we're going to go to the sensory. So let me get rid of this. Okay, so we did the motor, boom. All right, so sensory areas are on the postcentral gyrus. So that's this thing right here is the postcentral. This was the precentral gyrus, that's motor. Postcentral gyrus is somatosensory, somatic and sensory. So somatosensory right here. Oh, let's put what somatosensory means. So what goes to that part of your brain? Somatosensory, oops. Areas detect, no, not detect, perceive, that's a better word. Perceive touch, temperature, pressure, and pain. All right, so that's what's being felt in that blue region of your postcentral gyrus. So temperature, touch, pressure, and pain will be felt there. All right, now it's not good enough to just have a sensory area. You need to be able to understand what that stuff means. Oh, I don't want that anymore. Okay, you need to be able to understand in addition to, to sensing it. Okay, so it says somatosensory association cortex integrates sensory input to produce an understanding of the object being felt. And I'll show you what that means right now. Oh, and then primary visual cortex is on the extreme posterior tip of the occipital lobe. Okay, so touch, temperature, pressure, pain is parietal lobe. Let me underline some things. Okay. All right, so there you go. Somatosensory, parietal lobe. Touch, temperature, pressure, and pain. Vision is occipital lobe. Okay. All right, now we'll look at association areas. Okay, well, I don't want to do it right now. Yes, I do. Okay, so let's go back to this picture. All right, so this region, oops. So this region right here, primary somatosensory cortex, this is the, okay, so this is the perception of temperature, touch, pressure, pain. Okay, then we need to understand temperature, touch, pressure, pain. So that's this region right here. So this is understand it. So this region right here lets you understand what temperature, touch, pressure, pain is. So, you know, if you're checking to see if you have a fever and you touch your head, oh, am I hot? You need to understand what you're feeling is hot or what you're feeling is not hot, or all of the different textures that we can feel. So everything from perfectly smooth to rough and sharp and dry and wet and bumpy and soft and fluffy and all of that. Okay, all of that's going to go there. Plus, when you slam your finger in the door, that's where you understand you just slammed your finger in the door. You're going to feel it here, but then you're going to understand, oh, I just slammed my finger in the door. Yes, you have to understand that you felt you. Okay, so Felicity just asked, why does everyone have preferences in textures and tastes? That's all a learned behavior. And so, and it depends. There may be something associated with, you know, a bad thing as you were texturing, you know, you're eating something or feeling something, and you just have a bad memory that goes with that, that you don't even remember that you have that memory. It's just all, that's all cerebral cortex, this area. It's all association area, because these association areas are all tied together. We get different input, or well, we get the same input, but we get different output. We get different understanding, different feelings. So there is no explanation as to why we have those things. Although my daughter and I were talking Saturday about stuff that she just won't eat. And one of them is potato soup, because she had a bad experience with eating some potato soup and then throwing up afterwards, because she had the stomach virus already, and then she ate the soup and then the virus kicked in, and so then she was sick. So she won't eat that. And then what was the other thing? She now won't eat something else because of a bad experience with it. Dang it, I'll have to text her, have her remind me. And then I said, oh yeah, that's how I won't eat bagel dogs and drink Diet Pepsi anymore, because I had just, a bagel dog is like a big foot-long hot dog that's wrapped up in bagel dough stuff. And then I was drinking Diet Pepsi. And so I had just had those, and then I had my first serious, well, my first kidney stone, but it was a bad one. And I was so sick that it made me throw up. And so I can't eat those things anymore. So there it is. And yeah, I don't know why people sometimes have a real hard time with textures in food, or then we have, when we get into talking about adaptation, then we'll talk about why some individuals with autism have that sensory overload disorder thing. It's got a name, I can't remember what it is. How, you know, sometimes they just can't wear clothes, or they can't, that we have to decrease the amount of sensory input that's coming into them. We'll get into what's going on with that a little bit later. Okay, so yeah, I have no explanation as to why some people like this and some people don't. Okay, then we go to vision. So here is where we see from. So this is our primary visual cortex. So this is where the input from our eyes will go, but then this is where we understand what we're seeing. And so one of the videos, ooh, hopefully, yeah, I'll try to make it work, that I wanted you to, oh, where did I write that down? Oh, it's on here. That I'll have for probably for tomorrow, maybe I'll have it posted today, is a list, oh, there it is, of videos that you'll watch for next week or for tomorrow's lab, that we may not have time for. We may watch some of them, but I don't know. We'll have to see. Prosopagnosia. Okay. So we'll talk at length about this tomorrow because I have a cool story about that. What else do we need? Smell. So smell is these areas right here, right there in the temporal lobe, and then taste is also in the temporal lobe, and hearing and oh, let me get to a different picture. There we go. This is a picture that I wanted. Okay, so if we look at okay, so here is seeing, this is understanding what we see, here's what we feel, here's understanding what we feel, here is hearing. Okay, so this is hearing right here, this is understanding what we hear, number 22, the auditory association area. Now this area right here, okay, Wernicke's area or Wernicke's area, this is understanding speech. It's not just sound, it's specific for speech. Specific for speech. Okay. Understanding speech. Now, speech is a learned thing, you know, and so if I were to start speaking French to you and you don't have French in your Wernicke's area, and so you wouldn't understand what I'm saying, just as if, you know, someone from Germany were listening to me speaking English and they didn't have a training in English, then they wouldn't know what I'm saying, but they would know their respective languages. Okay, so that's what that's for. And then of course, here's Broca's area here for speech production. So see how you understand what's being spoken and then you go ahead and say it. Okay, and then what do we have? Taste is right here by where smell was, deep in where, oh, I don't have smell. Smell was on the other side, but it's taste and smell are right next to each other. Oh, let's just go there and we can. So here was smell, and then taste would have been, whoop, just came down on the other side right above it. So taste and smell are really close together. Okay, so what do we have? Post-central gyrus, we got, oh, okay, we already did that one. We did that. Okay, so visual area, occipital lobe, primary auditory, temporal lobe, cortex, olfactory, temporal lobe. We saw gustatory deep in the parietal lobe, near the temporal lobe, and the somatosensory area for the tongue. So we got all of that all put together. Okay, ooh, time to go. Last thing they want to talk about, and then we will finish this up on Wednesday. So we have one really important association area, and that is this area, this lighter pink area called the prefrontal cortex. So what is that? Our prefrontal cortex is what it takes to be human. So prefrontal cortex in the anterior portion of the frontal lobe is involved with intellect, complex learning abilities, so cognition, understanding, recall, and personality. Necessary for abstract ideas, judgment, reasoning, persistence, long-term planning, compassion, following societal rules, and conscience. So this is all your personality. This is all who you are. So our prefrontal cortex is all about being us. And it's closely linked to the limbic system. We'll talk about that probably, yeah, we will talk about it tomorrow in lab. Because the limbic system is like that reptilian brain part, you know, that's all our flight or fight kinds of stuff, helping us survive, which is turned into our emotional part of our brain. and plays a role in intuitive judgments and mood. So this is all who we are is found in our prefrontal cortex. And then we said Wernicke's area and other language areas on the left side for understanding speech. Oh, and that's one more thing that I wanted to add. Remember at the beginning of the video we watched with Hank, he said that that man had had a stroke and he lost his ability to speak because he had damage on the left side of his brain in his Broca's area. But on the right side of his brain, he has an area for singing. And so he trained through singing, he trained his right side to take over the functions of the left because speech is only on the left. So sometimes when a person does have a really bad stroke on the left side of their brain, that they do end up with aphasia, not being able to speak. All right, so wow, that 50 minutes went by in a hurry, friends. Okay, so there we go. That'll do it for today. And so we'll meet here tomorrow at 1 o'clock and we will do our lab. So you'll want to have your central nervous system parts. So all the stuff about cerebrum and cerebellum and midbrain and all of that kind of stuff. Make sure you bring your yellow packet and your lab manual to class tomorrow and or whenever you watch this. And so then you can know which pictures we're looking at and can follow along. All right, so if anybody has any questions before I get rid of this.
I have one question. I was wondering why it's opposite, like our brain and our sensory stuff is opposite.
Yeah,
like,
I'll show you that on Wednesday.
Okay, thank you.
You betcha. Thanks for asking, because we will cover that, because that's everybody's question. Why does it like that? But it'll totally make sense when I show you on Wednesday. Okay, if nothing else. Okay, thanks for coming, and I'll post this in about 15 minutes. Okay, bye.